Welcome back to Open Globe Talk. This is your host, Ruslan Nathani, and I am joined today with Dr. Craig Chaya, who is an assistant clinical professor at the University of Utah and the division chief of its global ophthalmology department. Dr. Chaya completed medical school at Loma University School of Medicine and an ophthalmology residency at Texas Tech University. He completed 2 ophthalmology fellowships, one of which was an international ophthalmology fellowship as a Freedom Foundation Fellow through the Himalayan Cataract Project in Nepal, and another in Glaucoma in the University of Utah. Dr. Chaya's global work has encompassed work in Nepal, Thailand, Haiti, Ghana, Guam, and Micronesia. His research interests are in preventing global blindness and developing novel glaucoma surgery devices with specific attention to customized and holistic care. As one of the prominent leaders in global ophthalmology, we are very glad to have him here today and learn about the sustainable approaches to how we can better our healthcare delivery systems. So without further ado, I just want to welcome Dr. Chaya to the show.
Thank you, Rizal. It's a pleasure to be here.
Yeah. So Dr. Chaya, like I ask everybody, what got you interested in ophthalmology? And something that our listeners don't know is that you had already completed an internal medicine residency. So you had a vast knowledge of medicine even before having entered into ophthalmology.
It's a great question. I would say my path is somewhat circuitous, but it's also, I think, has shaped the way I practice medicine too. So initially, when I was in medical school, I had very little exposure to ophthalmology. And it was only during a 3rd-year surgical block where we had to choose a surgical elective to perform that I happened to stumble into ophthalmology. The actually subspecialties that I was interested in, ENT, urology, I think there were some others that were quite good experiences for medical students, were all taken up. There were no more opportunities for medical students. So I reluctantly called the ophthalmology clerkship director and said, is there availability? Or actually our surgical clerkship director and said, what's available? What can I do? What are my options? And they said, well, there's plenty of opportunity in ophthalmology. There's lots of spaces available. So I said, all right, sure. It's a week. I'll go ahead and take care of it, complete my mandatory elective time. And I did that. And so I arrived onto the ophthalmology service at the VA in Loma and walked into the first room of a patient that I had no experience with. And the first thing was basically a hug and a virtual, almost a kiss from this patient who said, thank you so much for helping to restore my vision. And I just had to politely say, it really wasn't me. I'm a medical student that just got on service here. But, I'm super excited for you. And so I just proceeded to be a fly on the wall, so to speak, to observe this interaction with the resident and the patient. And I just saw the profound impact that restoration of vision had for this patient. And I was moved, and I had to go back home and really reevaluate my career decisions. Up until that point, I was heading towards likely being an oncologist, and I liked that type of work. I appreciated the patients, I appreciated the long-term follow-up. All these things were intriguing to me about oncology, and also being at a stage, at the patient's stage of life where they're seriously considering things like mortality and all these things that I thought were really attractive about that specialty were just blown away after I did my ophthalmology rotation. So I was a late comer to ophthalmology, and I didn't match the first time around. I didn't really have an understanding of what it took to. It was competitive then too, but I would say even more so now. But back then I just had no idea. I really had no exposure to ophthalmology. So it took me a while to really settle into the idea that this is what I wanted to do long term. So fast forward, I was in my internal medicine internship, and I had to make a decision about whether I would reapply again right away. My wife was actually in graduate school or entering into graduate school at the time for nurse practitioner school. And we personally just had to make a decision for our own, for the sake of our relationship, whether we would decide to be apart for a while or whether we would go ahead and just wait until she finished. So we opted for the second. We opted for her to finish her schooling so that we could move together and be together during that time. And so second time things worked out well, but in that time period while I was waiting for her to finish, I had the opportunity to finish my internal medicine training. And so I took that both as a way to round out my education, but I was clearly interested in medicine and wanted to pursue that as well. And so I just felt like this would just be, for me, ophthalmology would be my fellowship experience, so to speak. A lot of fellowships in internal medicine are anywhere from 2 to 3 years. So I thought this was how I would shape my career, as I would have that kind of solid internal medicine background and then pursue ophthalmology as my fellowship, so to speak. And so that was kind of my journey to ophthalmology. It was a little bit circuitous, but I think it shaped me into the person I am today.
I think that journey just sounds so familiar to me as well. I actually, was very interested in oncology, didn't know how to incorporate it. And likewise, you get the inspiration. You always have that inkling, at least for me. I really loved ophthalmology, but you really discover it through these rotations when you're right in the moment of deciding what you want to do for the rest of your life. And I really loved how you showed the personal sacrifice standpoint, but never really giving up on that dream and kind of going for and developing a career out of the vision that you saw when you were in those rotations specific to the specialty. And you're right, it's not like, a path is always very straightforward, even if one picks in, ophthalmology or whatever specialty they want to pursue. I think everybody's path can be very circuitous in the way that they lead it eventually. It's of interest to me that you ended up pursuing glaucoma, and I'm sure that too has a story behind it because glaucoma is one of those very interesting subspecialties that has a very nice parallel to medicine itself. And I wondered why you ended up choosing glaucoma eventually.
Yeah, I would say it's for a variety of reasons. As I was exposed to different specialties in ophthalmology, it was certainly the patients that I gravitated towards. I really appreciated the longitudinal follow-up for a lot of these patients. And, I came from a background of managing chronic disease in internal medicine. So similar to hypertension and diabetes, glaucoma is a longitudinal disease, a chronic disease. And so those were things that were naturally intrigued me about this specialty. And also it was at a time of, we were just on the cusp of all these great innovations that have occurred in ophthalmology. It's, I just heard this the other day from one of our representatives, that industry representatives, that, glaucoma, this space and glaucoma surgery and innovation is one of the fastest growing areas of ophthalmology in the last 10 years. And it certainly has borne out that way. And so we were just starting to hear glimmers of this when I was a resident. And so that was another area that intrigued me about glaucoma. I would say the other big reason for me is I knew that I was interested in global health and global ophthalmology. And as I kind of looked around the world and saw what the major causes of blindness were, cataracts and glaucoma were at the top of the list. And so I felt it would be important for my training to understand how to manage the disease and in order to be an expert in that area. So that's another reason, a big reason why I decided to choose glaucoma training as part of my subspecialty training. Yeah.
Yeah, I'm glad you mentioned how the period that you kind of train in really influences you, especially with how innovations occur in these different subspecialties. I've certainly heard about, from colleagues as well as mentors who have mentioned very similar things where, as for example, retina at one point did not have as much innovation, but eventually when it did, it really piqued the interest for them, and that's how they ended up in that route. So rightly so, and glaucoma is rife with a lot of innovations, and you currently work in that area as well. So you mentioned your fellowship with the Himalayan Cataract Project or interest in global ophthalmology. I'm interested to know how you were able to pursue your global ophthalmology fellowship even before it was called a global ophthalmology fellowship.
Yeah, wow, this is a great question too. As I think back now, you're asking me all these questions, looking back and reflecting on my past. And, some of this I think is being at the right place at the right time. Some of it I think is providential. When I think about even my start in ophthalmology, I think that, what would have happened had I not been in that situation where I had to do a surgical elective in a specialty that I wasn't really interested in, right? And so some of these things were just, you know, fortuitous and providential that they all worked out this way. But particularly for this one, for the Himalayan Cataract Project experience, Dr. Jeff Tabin was a professor here at the Moran Eye Center when I was a fellow, and he was great friends with my mentor, Alan Crandall. And so, although I was not in Dr. Tabin's clinic, Dr. Tabin was a frequent visitor to our clinic to come by and hang out and chat and just talk about life and things in general. And that's when I had an experience with him, just to ask him, you know, what opportunities are available. In fact, the year that I was a fellow here at Moran, Dr. Tabin had, I think, his first global ophthalmology fellow, Mike Fallmeyer. We were fellow mates, and he was the token, or I guess the inaugural fellow for this global ophthalmology fellowship. I really had been none up to that point, or I don't think in an intentional fashion there hadn't been one at that point. And so I learned about global ophthalmology a lot through my fellow mate, Mike Fallmeyer, and then also my interactions with Dr. Tabin and my mentor, Dr. Crandall. And so it was really, I think, Dr. Tabin who said, you know what, if you really are interested in being in the global ophthalmology space, it's important that you learn how to do manual small incision cataract surgery. And we can help you with that. We have opportunities available after you finish your fellowship. You know, you want to go to Nepal and learn how to do this from the masters, so to speak. And I just, you know, just couldn't believe that this opportunity was before me. And so I gladly accepted and said, yes, I would love to be able to go and be able to spend time with your colleagues in Nepal and learn how to do this type of surgery. Up until that point, really, none of my residency training or even fellowship training had I been exposed to this style of cataract surgery. So I was sent to Nepal for about 6 to 7 weeks after my fellowship. I graduated, and I spent a couple of weeks in Kathmandu, you know, watching Dr. Ruid, Sanduk Ruid, doing surgery, and all of his all the people that he had mentored. You know, most notably Suman Thapa, who's a glaucoma specialist, and also Ben Limbu, who was, you know, one of my great surgical mentors there. We had just a great time together, just talking about life and being able to see how the system worked was really important to me. Understanding how that process of mentorship and education and how that really exponentially creates the impact that a place like Tilganga has had was, you know, I think a really formative experience of my fellowship time. So it was really a mini fellowship. It was kind of compressed, but I was able to do a lot of surgery in that 6 to 7 weeks. That was important for me to be able to do a lot of cases, to be able to have that experience. And so, yeah, that's how it came to be that I became, you know, kind of an HCP fellow, kind of a mini fellowship for that summer.
That's pretty cool. Just kind of listening to that is very nostalgic in some ways, because it kind of shows how much the Global Ophthalmology Fellowship has changed since then. Now fellows are spending, you know, close to over half the year, in fact, maybe even 9 months abroad. And I wondered if, you know, when you were there for 6 weeks, how did you kind of have ideas on maybe how the fellowship could be built on, and if it was apparent that spending more time abroad was actually the more appropriate fit for the content of that fellowship?
Yeah, you know, if I knew then what I knew now, I would certainly have spent more dedicated time in global ophthalmology in that space, because right after my fellowship training was the perfect time to do this. I had no practice obligations. I actually took my family with me. We went to Nepal together. I had 2 small children at the time, and so for us as a family, we felt like this was an important experience that we wanted to do together. So they traveled with me. You know, we had that special time together. My kids don't remember much of it. They were very young at the time, but certainly my wife, it's a very important memory that we have together after we finished our training. And so I think it was just important for me to understand the scope, right? I had really, up until that point, it was just cognitive knowledge about understanding what the global burden of blindness was and the impact it would make in low and middle income countries. And so being there in a place where there was so much innovation in terms of reducing disparities and making care more cost effective was just an impactful time for me. And so although it was short, I gained a lot of knowledge just in terms of how systems work and what it takes to actually make a dent in global blindness. Nepal was at the time and still is one of the few countries that is able to keep up with their rates of blindness and manage that well. And so for me, it was important to be there to understand how these systems work together. And I think what the other thing that I was able to I was impressed by was just their system of education and how built into their system is a little bit of polite obligation, so to speak. I think when the trainees come through that program, they're so grateful for their training and they feel indebted to the institution to give back. So many of the Tilganga residents go on to do subspecialty training and then return back to the institution to give back to younger trainees. So I thought that was really beautiful, just how it all came full circle and how there was a continued interest for people to give back to their program and to nurture the next generation of ophthalmologists coming through.
Yeah, rightly so. Just like Dr. Sanjay Gurud had done, he came back to the country and
Right.
really built Tilganga. So that's really cool to
Right.
have his trainees kind of mirror his way of his path essentially.
Right.
It's funny you mentioned that you brought your family for 6 to 7 weeks there, and I feel like that's a big commitment for a family, especially in a country where maybe you don't speak the language. I'm curious if that ever influenced you in terms of where you wanted to focus globally once you came back, and it ended up becoming a fellowship director at the global health director at Moran.
Yeah, it was certainly an area that drew my wife and I together. We both had a personal interest in global health, and so I think it was a natural fit for us to do something like this. And I would say she's probably more adventurous than I am, and I had a little bit of trepidation thinking about how we were going to pull this off. But she jumped, feet first in, and she was ready to go. And so we made it work. It was certainly, not the most smooth time. We had to make a lot of adjustments along the way. Just, imagine traveling. It's already difficult enough to travel alone sometimes, but traveling with small children certainly magnified that. But it was a challenge that we just embraced, and we knew that we would look back fondly on that time. And so, in fact, my journey in even in academia and global ophthalmology is such that I had no intentions. It's funny how a lot of these things just don't happen the way you plan them. And my time in global ophthalmology has been like that too. In fact, we knew that we wanted to be overseas for a while after my training. And after Nepal, we wanted to be close to Asia. That's where my heritage is from. My family's from Thailand. And I wanted to spend some time there. But there were some barriers to actually practicing in Thailand. They were going to require me to take boards in Thai, their version of USMLE, et cetera. And I was just at that point in my life a little bit exhausted from having to take tests and study for exams. And so we were actually pivoting. We were looking for opportunities to be close to that part of the world, but not necessarily be in an Asian country. So we're actually looking at practicing in New Zealand, where I could practice in their system. I could spend anywhere from 6 to 8 months in the New Zealand healthcare system and then have the rest of the time off to maybe do work in areas that I wanted to. So that was my initial plan after we had finished our training. And we actually back up a little bit. We were in Guam. I knew that we were going to be in Guam for a little bit. We spent some time there. It's a U.S. territory, but it would put us closer to Asia. And so after our time in Guam was over, we were actually going to pivot towards New Zealand. And that's when I ran into my chairman, Dr. Olson, at a meeting, and who informed me that things were taking off back at Moran, that the global division was starting to formalize, and really the program was really going to start to grow significantly. And would I be interested in being a part of that process? And we had to decide, were we going to follow our initial plan, or were we now going to head back home to the States, where we might be able to have the resources and the support of a world-class institution, but also be able to have the impact on future trainees too. And, ever since I was young, I always thought I was going to be a teacher, and I didn't know what capacity I'd be a teacher. And so when the opportunity came up to come back to Moran to actually be a part of our training program and and also still to be a part of the global ophthalmology family, we decided that this would probably be a good fit for us. And so, fast forward, I've been here for 10 years now, and continue to, advocate for global ophthalmology and the experience for our trainees. But it's grown so much, as you've seen in the last year. And even in your short time in global ophthalmology, you've just seen so many people who have really elevated the conversation and are really passionate about moving the needle forward.
Yeah. I mean, a lot of things happen serendipitously, but you were at those like very crucial periods in, your life and in general for global ophthalmology, where Dr. Tabin had already started this fellowship, but then, the momentum was being gained for its importance. And nobody could have imagined that global ophthalmology would have become its own fellowship. And I'm really excited for other fellowships that could sprout out from that, because it is a very big field. So when considering bringing novel technologies to underserved regions of the world, where would you say you could pull from resources? Because this is something that you have an interest in. And I always wonder when, people are creating new technologies, it's so much harder to implement them in, developing nations where maybe the interest for industry is not necessarily realized.
Yeah, no, it's a great question. Particularly for glaucoma, if you think about glaucoma and the challenges that we have in glaucoma and managing glaucoma, there's no one-stop shop. There's no instant cure. This is a chronic disease that needs to be managed. And we also, if you look at a lot of glaucoma surgeries, even our best surgeries, many of them end up failing over time, right? And so we do need better techniques. We do need safer techniques. And I think this is the area that I'm excited about, because if you look, a lot of the published data on the global burden of glaucoma, these are patients that have already been diagnosed or already have significant vision loss, right? But there are a lot of patients, I think it's estimated, probably close to half of patients with glaucoma in the world don't even know they have it yet. And so the innovation doesn't happen only in treatment, but I would say the innovation is going to need to happen in terms of diagnosis, right? And managing these patients long term. And so if you can diagnose early, you can certainly have better outcomes. A lot of the innovation that's happened in MIGS, for example, these devices are great, but they really work best in the hands of early glaucoma, right? Or in the setting of early glaucoma. If patients have very advanced glaucoma already, it may have minimal impact on their long-term outcomes. And so I'm excited because as I've spent a little bit of time working with some Indian colleagues who are just so thirsty for knowledge and so thirsty for innovation, because they're dealing with just the sheer magnitude of glaucoma and how many patients are suffering from glaucoma. And so it's really interesting to see how in the last 5 years, I've just kind of watched how innovation and in the MIGS space, for example, has spread throughout the world. And you'd be surprised the number of people who are doing really interesting, creative things in order to innovate that are still very cost effective, right? And so I'm excited for that. I think there's an implication that if you do innovate, that it has to be expensive. And I think my background in global ophthalmology has really grounded me to say that, yes, it's important to innovate, but is this going to be a cost-effective solution for the world? And in some cases, the answer is no. And in some cases, the answer is yes. And so I'm intrigued by both, right? I'm intrigued because I think there are lessons that we can learn both from innovation that's more expensive, some lessons that we can learn. But I think one of the challenges for doing this in low middle income countries or low resource settings is reproducibility. I would say it's also having to do, if it involves a device, how are you going to manufacture a device? And ultimately, I think my background in academia implores me to be thoughtful in deploying these technologies. So I think research is important, right? I think finding good partners to do this research is important. I think full disclosure to patients is also important. Helping patients understand that, this is a novel technology. It seems to work well in our population here in the United States, but this is a new technology we're bringing to your community. And I think doing that in a thoughtful way also means having partners on the ground that can help you, right? Understand the culture, understand informed consent, with different groups. And I think that's critically important. I don't think you can do those things just nilly-willy. I think it would be unethical for you to introduce novel technology into a space just because there's no FDA, for example, or no IRB, right? I think you need to take those same ethical considerations when you're doing work in the global space.
No, I think you hit all the points in terms of, how things can be replicated in another setting. And it's interesting that you bring the informed consent aspect because, some governments have an informal method. It's not very centralized, but at the same time, when you're coming from the United States and you expect the similar treatments to be offered to patients abroad, it can't be that you change the standards. That would just seem very unethical. And so kind of navigating that is definitely an aspect to consider. And one thing that I always find interesting is, for example, cataract surgery has been reduced in terms of its price substantially in places like India. And so it's kind of interesting where we pay a substantial amount here in the United States, but then have such a low cost burden in another country. But of course, the quality is a little bit different as well. How does that kind of work in parallel when you have a high cost method and then you have a low cost method? And maybe making it more available here in the United States too, would that kind of jeopardize some of the price structures and the way healthcare is delivered in the United States, because we do have underserved populations that may not be able to afford a cataract surgery at the ready as well?
Wow, this is a big one. I have a little bit of an interest too in policy and how that shapes healthcare. And wow, this is a difficult one to really unravel and come up with meaningful solutions. I can just tell you what we do here at the Moran. I think this is what's one of the things that global ophthalmology has taught me is to be resourceful and look for ways to get things done despite all the barriers. And so if I have patients who are uninsured or are underinsured, we're always looking for ways to make sure that we can still deliver that care. Because I think we all know that delaying care and not providing the care just economically is going to be bad for our communities and bad for our society. Just the amount of lost productivity if we delay care and if we don't treat things promptly. And so I think one of the things that we do is we're always looking for great partnerships, people that are interested in meeting those needs and providing those stopgaps for patients that can't otherwise afford it. But I do think that let me just give you an example of I think something that is shaping this country right now. The conversations around cataract surgery and the cost. And this is a bit controversial, I will admit, but it's the idea of, do we really need to be performing cataract surgery for all patients in a hospital-based setting or an ambulatory surgery center? There's a significant cost to be able to provide cataract surgery in a hospital versus an ambulatory surgery center. But this new setting, what's titled office-based surgery, is kind of a novel concept, it seems, to the United States. But really, this is something that our partners have been doing around the world, providing what we call office-based surgery with little sedation and really not having the type of anesthesia support that we typically require in this country. And also in terms of just utilizing resources properly. And I think what we're going to see is that the cost of cataract surgery is also going to decrease in this country as we're able to perform cataract surgery in different settings. So the idea behind office-based surgery is that you can now do this more conveniently in your clinic in a space that's still set up for surgery and still has all the great safety measures that you would have in an office or in an ambulatory surgery center or a hospital. But maybe you really don't need to place an IV, for example, a peripheral IV in every cataract patient, or you don't need a significant amount of sedation for every cataract surgery patient. That doesn't mean that those other settings are not needed, you will have some patients inevitably, for example, pediatric patients, that's not going to happen, right? You're going to need a hospital-based setting with a good anesthetist to be able to take care of children. But I think for most cataract surgeries, routine cataract surgeries, I think it's very reasonable to think that these could be done safely in an office-based setting. And our partners around the world have already done this. And I think they probably laugh when they hear the conversation about office-based surgery here in the United States, because this is something that they can say, we've been doing this for decades. We could have shown you that there's good safety track record. I mean, Aravind, for example, the sheer, probably millions of cataract surgeries that they've done now, I mean, has excellent safety track record and excellent safety data. And so we have so much to learn practicing here in the United States in terms of innovation that's happening around the world. And that's why I'm super excited to be able to go to places where, I think would be labeled as low resource setting, but they're doing amazing things with low technology or little technology, but still making meaningful impacts in terms of improving quality of life, improving rates of blindness, right? So I think when I think about innovating and bringing new technologies and the challenges that we have here, I'm drawing lessons that I learned from other parts of the world where I've practiced or where I've had the opportunity to observe, and trying to apply that here to make cost or care more cost effective. But I think also it's a mindset too. It's a mindset, it's a training and mindset to say that, what, there's got to be a solution. There has to be a way. We can't just use the status of insurance or no insurance as a metric to say that it's possible, right? So I've tried to eliminate that from my conversation. Oh, a patient doesn't have insurance. Okay, what programs do we have available? And then we're looking for resources. We're looking for ways to make it happen, right? And I'm fortunate to practice in also in an environment where, the University of Utah, the Brand Eye Center understands that. We understand that we need to find ways to meet the needs of our community, because in the end, it's going to cost all of us to take care of patients who have not had appropriate care.
Yeah. Great example. I think that really, goes into showing how far behind we might be with respect to some countries that we may not have thought are as advanced, compared to us. And the fact that, institutionalized medicine has kind of compacted ophthalmology within it, and now we're kind of slowly coming out of that model. It's really interesting, and it parallels some of the fragmented healthcare models that we kind of experience in the US. But this is one of those models that is actually beneficial because it can help address some of the disparities in treatment. So really great points. You speak about community, and Navajo Nation is one of the most important communities in Moran, just because the locality and the proximity, and as well as how many individuals are underserved in those communities. You've been pretty instrumental in some of the teleophthalmology initiatives at Moran, and I wondered, what were some hardships and some ways that you were able to overcome the communication barrier and treatment barriers that occurred during the pandemic?
So particularly for the Navajo Nation, I must give a lot of credit to my colleagues that have really laid the groundwork for this to happen. We got introduced to the work on the Navajo Nation because one of our former directors of global outreach, Michael Ye, and Michael had a lot of experience doing work there and really introduced our group to the significant need down there. Prior to that, we really were in the dark in terms of the significant need that was down there. And so I think for the last 10 years, we've been working down there. A lot of it was relationship building a strong amount of trust that was probably missing. Okay. And so I think it was important for us to go in with humility and to be respectful of the impact that or the impact of blindness that has had on the Navajo Nation, and to really understand their quality of life. And we had to learn all those lessons slowly over time. So I don't want to give you the impression that suddenly we had all this knowledge and we just arrived on the Navajo Nation and we were saviors for vision care. We really weren't. I think for us, it was initially going and listening, understanding the the culture, understanding the context of how people's quality of life were affected by things such as limited running water, limited electricity, and also access issues, right? The nation is quite large, and I would say probably the number one issue, one of the number one barriers is really access to care. It can take a long time for people to travel off the Navajo Nation to seek care with subspecialists or even specialty care. There is a great network of primary care there throughout the nation, but I think like most places, subspecialists were lacking. And so we needed to understand all that and how it impacted people. And so we did things just very slowly and methodically. During the pandemic, I would say we wanted to remain connected. The Navajo Nation actually closed their borders for a period of time where we were not allowed to go down there. There was a lot of concern for making sure that COVID wasn't spreading, and particularly by us not importing COVID into the nation. And so we had to come up with creative ways. So, Lori McCoy, my current director of global outreach, came up with a system where we had representatives throughout the Navajo Nation, nurses and technicians that could be our eyes on the ground. And we really did that through just very basic means. We created an online spreadsheet, and that spreadsheet was updated on a somewhat weekly basis by our representatives there. And we use it as a remote triaging system. If there are patients that needed attention right away, we brought them up here to Salt Lake City or brought them to nearby providers to be able to provide that care. We weren't able to do a lot of things that we typically do, such as screening, but we tried to provide some level of care so that it just didn't come to a complete halt. So those are things that we did. In terms of the teleophthalmology work there, some of this work was already done by some of my former colleagues. Meg DeAngelis is a researcher who had the idea of actually doing teleretinal screening there on the Navajo Nation. And that's just starting to pick up, I would say. It's been done at a very low level right now, but we're hoping to jumpstart that. And I'm really fortunate to have some champions that I work with. Dr. Eric Hansen is one of our retina specialists here at the Moran, and also one of our residents, Sean Collin, has been a champion for teleophthalmology and how we can use teleophthalmology, teleretinal screening, and AI, and how that will hopefully improve our workload and it actually make things more efficient and get patients the timely care that they need. And so I wouldn't call us experts in the field yet, but we are certainly excited about the opportunities, particularly for how this work will impact our work on the Navajo Nation.
Yeah, and you mentioned about diagnosis of glaucoma, and that's just one of those things that was very difficult to do when the pandemic occurred, and we didn't know if it was going to be 6 months and it ended up being much longer.
Right. I think we all had to get creative. Those of us, I think teleophthalmology or telehealth works well for some specialties, but at this stage right now, we're on the cusp of it. It's already happening around the world, but we still need to see patients, and we still need to be able to examine them. But that gap is closing, which I'm thankful for. I mean, we have partners that we're working with in Mexico, for example, at the IMO Institute there. And they're doing teleophthalmology at a very high level. They're doing virtual exams. They have a slit lamp adapter where there's an optometrist on one side actually performing the exam while an ophthalmologist is on the other side watching the whole exam in real time. So it's quite fascinating how resourceful people become when things like a pandemic occur. But I would say in general, these are the I would say it's silver linings of the pandemic, that it's taught us to become more resourceful and how we can still provide a high level of care, even tertiary level of care, without necessarily, having more resources than we did before.
Yeah, and it also highlights some of the strengths of ophthalmology in that sense, just because, listening to someone's heart is fine, but doing it, far away, it's a bit difficult. But then looking at a person's eye from far away virtually can give you a lot of details, especially with the digital technology that ophthalmology is really focused on innovating ahead of time.
Yeah, just one thing I'd add about, just telehealth in general. I by no means feel that telehealth will ever replace the doctor interaction. I think there's something very powerful about being present in a room with the patient. particularly for glaucoma, where people are worried about losing sight.
Mhm.
And so while telehealth will have a role in terms of increasing our efficiencies and getting to people sooner, I by no means feel that it will ever replace having a provider relationship, right? I really feel that there's a connection that happens when you see patients on a regular basis. There you can communicate so much more effectively. And so I'm a big fan of in-person visits, don't get me wrong, but I'm also a big fan of technology and how it's going to allow me to get to patients faster and sooner and hopefully reduce, morbidity and improve their quality of life. But
Yeah,
so we need both.
definitely. And glaucoma is just one of those diseases that really parallels medicine, and quality of life is a very important issue. Sitting down with them certainly changes a person's thought process and how they adapt to their disease, because it is progressive. So you're absolutely right. Um, one of the last questions I kind of wanted to ask, and it kind of touches on your global ophthalmology leadership, is what would you say is something you would like to see um, maybe enhanced over the years in a global ophthalmology department? What are some, things that you think are still under addressed or still in the process of development?
With regards to global ophthalmology, is
Training,
that
yeah.
your question?
Mm-hmm.
Yeah, I would say this is, I guess I'll speak based on my particular experience or my desires right now. One of the weaknesses that we have as a global ophthalmology division is how to do advocacy well. And I think giving a voice to those that are both underrepresented, but don't have a powerful voice is super important to moving global ophthalmology forward. And so, this summer we had the opportunity many of us had the opportunity, and I think yourself too, to attend the Global Ophthalmology Summit. And Brooke, who represents she's the policy manager for IAPB. I think really just hit home how important it is to be a part of the conversation at a high level with those people that are going to be changing policy or formulating policy. My mentor, Alan Crandall, used to tell me this all the time. He was someone that really didn't enjoy politics for politics' sake, but he said if you really wanted to be a part of the solution, you had to be a part of the politics. And not that you had to be a politician per se, but you needed to be in the room with people that were making decisions on behalf of others. And so advocating for them and advocating for how important vision care and vision health is, I think is an important skill set that I want to get better at personally. And I would say that is an important lesson that I would want to have all of our global ophthalmology fellows and fellowships really pay attention to, the importance of advocacy. And that could be done on a small level. It doesn't have to be, rubbing shoulders with health ministers at the UN like Brooke is doing. But I think it's understanding how healthcare is shaped in your particular area or in a particular country that you're working in, and looking for opportunities, whether it be through social media, whether it be through letter writing campaigns, or having that fortuitous encounter with somebody who is at that level. And you may only have a few minutes, with that health minister from the Congo or that health minister from Tanzania, but preparing for that moment. What would you say, if you had 5 minutes with a health minister from another country, how would you advocate? I think this is an important lesson that I haven't always prepared myself well for, but I want to improve in. But this is an area that I think would be great, to be kind of a core metric, or, kind of a core competency, to use the residency language that we use right now. A core competency for our fellows to learn is the importance of advocacy work.
This is a very apt message to send, and a very inspirational message to send, just because we are our voices. We are the voices for our patients, and we need to make sure that we use the periods that we have in training to voice some of the things that we're noticing are of utmost importance. I feel like when we go into private practice, we may see these issues, but we might not necessarily have the structure to voice those opinions. I think in training, it is one of the most powerful periods of your life just because you have that network of people you're learning from and kind of leaning on. And so, like everything in our open globe discussion, this is one of the most important talks that I've had. And I can't believe I shared so many similarities with you, Dr. Chaya, in terms of, teaching, as well as, how you gained inspiration into ophthalmology and just the worldview of approaching global ophthalmology. It's really a journey, and it shows that nothing in life is as straightforward as we make it out to be.
Right, for sure. No, I agree with that wholeheartedly.